Hello, everybody. Welcome back. We're getting ready to go to our case presentation. Our presenter is Dr. Raj Gandhi, who is a professor of medicine and infectious diseases at Massachusetts General Hospital and Harvard Medical School. He's also chair of the IAS-USA antiretroviral therapy guidelines. Also joining us on the panel, as you see people popping in, we have Dr. Masur, who will be participating, Dr. Ghanem, who you just heard from, Dr. Brooks, who you heard from earlier. Also joining us is Dr. Wendy Armstrong, who is a professor of medicine and division director of infectious diseases at the University of Colorado in Denver, and will be indirectly hosting the CROI meeting coming up in February, just because she lives out there. And Dr. Carolyn Chu, who's a member of our scientific advisory board and is a professor of medicine at San Francisco General, and is also involved in the warm line that you heard Dr. Brooks refer to earlier as a great resource for all of us. So, Dr. Gandhi, I think I will turn it over to you, and we look forward to having a robust discussion. What I'll do, we have an hour or so dedicated, or actually, yeah, about an hour dedicated to this, but we also have Q&A. So I'll incorporate questions as we go along. So we'll just go to 4:20 with this exercise. So we have an ample amount of time. We'll incorporate questions from the audience as we go. And Dr. Gandhi, I will turn it over to you.
Terrific. It's great to be here. Are people seeing my slide okay? And are they
Yes.
hearing me okay? Terrific.
Yep.
All right.
Both.
So we're going to jump right in. I'm going to go through a number of cases that I've seen in the last few years, really to just illustrate some points and get our panel to weigh in. And our co-chairs, Drs. Masur and Saag, are not going to be spared. They're going to be active members of the panel as well. So let's go ahead and launch right in. Here are my disclosures, or lack thereof. And what we're going to do here is talk about a couple of learning objectives. One, to start ART in people with cryptococcal meningitis. We'll talk about people who've had hepatitis B exposure and switching ART, and then we'll discuss weight gain, but there'll be actually other learning points along the way. So let's start with our first case. This is a 50-year-old woman with HIV. Her CD4 count is 20. Her viral load is 500,000, and she presents with fever and headache. She's not yet on treatment, antiretroviral therapy. She's diagnosed with cryptococcal meningitis and started on induction therapy with liposomal amphotericin plus 5-FC. So get your voting fingers ready, and we're going to go ahead and ask you to jump in and say, when would you start this person on antiretroviral therapy? A, at the same time as antifungal therapy, simultaneous. B, about 4 weeks after starting antifungal therapy. C, 6 months after starting antifungal therapy. Or D, complete a full course of maintenance antifungal therapy and then start ART. So I know that people are hopefully voting. Um, and I just see results just here. So about uh, three-quarters roughly would wait about 4 weeks, but a couple of about 25% would launch right in at the same time as antifungal therapy. So let me let one of our co-chairs, Dr. Saag, jump in first, and then I'm going to see if Dr. Masur agrees or disagrees.
Okay, thanks. Yeah, this has been an area that has evolved over the years. Some of the concern about starting right away is that there might be an iris type picture that could develop and that could affect long-term outcomes and especially maybe an intermediate term outcomes with mortality. There has been a really well done randomized trial that was released about 10 years ago that was mostly done in sub-Saharan Africa, where it showed that the deferred therapy of waiting to 4 weeks or longer had better outcomes in terms of mortality. And so it's pretty easy to just say, okay, those are the data, and that's what we would recommend. I push back a little bit on that because A, in that study, overall mortality was pushing about 25%. That's quite a bit higher than what we see in the United States, Canada, Europe, Australia. And so, for folks who are living in those countries or the developed world, if you will, there was another study that was not a randomized trial, but a cohort study done by the ARC-CC based out of Bristol, England. And those data, roughly about 200 individuals, received care in real time, but retrospectively were analyzed. And those data showed that more immediate therapy in the first 2 weeks was not harmful. And in fact, actually was a little bit leaned towards being superior to delay of therapy. So personally, I might wait a week or two, and then conservatively at 2 weeks, I might start the antiretroviral therapy based on those data. The understanding is, however, is that in those settings, frequent monitoring of intracranial pressure, I think really helps improve mortality. And indeed, in the original studies of amphotericin B from 1992, done by the mycosis study group in the ACTG, they had some of the lowest mortality, and part of that was because they were looking for time to clearance of fungi from the CSF. So frequent LPs were being done. If it was elevated, then folks would have even more common lumbar puncture. So I really think it's all about the management of the ICP and
Right.
cranial pressure. And if that's the case, then I think we could start a little earlier, but that's a personal opinion.
Terrific. Let's see if Dr. Masur, who leads one of the leads the DHHS OI guidelines, wants to either agree or disagree. And I can't see every one of my panelists on my current screen. So if people have additional comments, just do the raise hand function and it'll get your picture to move on my screen, I think. So Dr. Masur, what do you think?
Yeah, well, it's always complicated to disagree with Mike Saag. So I disagree. I mean, I agree in general. But I think there are a couple of things that people should just make sure they understand, and that is, no matter how you treat the cryptococcal meningitis, no matter when you start the antiretroviral therapy, cryptococcal meningitis is a bad disease, and there are a lot of people who have complications. So that I think how you manage them depends on, as Mike said, how carefully can you monitor the patients and Raj is going to get into whether you should give somebody one dose of amphotericin and send them out of the hospital. But being able to watch patients carefully is important. Number one, however you manage them. And number two, it depends a lot on how experienced you are managing cryptococcal meningitis. And when is a little bit of a headache or a little bit of neurologic dysfunction, when does that mean that you should wait a little bit longer on the antiretroviral therapy or back off on it? I think if you don't have much experience, it's much better to wait longer than shorter. And if you can't follow the patient, but if you're Mike Saag and you have the patient as an inpatient, a very reliable outpatient, you could probably go earlier. But I'm not eager to start earlier just because at least the patients who self-select by getting admitted for a long period of time, they tend to have complications. I don't know what other people, I'd be interested in what other people do. And I know there's a lot of push to get people out of the hospital, but I'm just impressed at how many bad outcomes there are with cryptococcal
Yeah,
meningitis.
yeah. We'll make a couple of points to pick up on where we are, but let's ask Dr. Armstrong to say her perspective, and then we'll just make a couple of summation points. Go ahead.
Sure. I would agree with you that the truth is somewhere in between on this, and it's really a patient by patient judgment. And, I've seen folks who come in with cryptomeningitis and you start, they don't have ICP issues, and you start them on amphotericin and they're better very quickly. And those folks I feel much more comfortable starting early on. And the person who has an incredible burden and you're struggling with their ICP and you're, tapping them regularly and they have neurologic issues that take time to resolve, I feel much less comfortable starting early. So I think that there is something about how well somebody is responding and how sick they are that helps me make that decision.
Terrific. I think we've got all the main points here, which is really it's when the crypto comes under control. And just very briefly, because we're going to go through at a pretty good pace a number of cases. Initial treatment is acknowledged to be liposomal amphotericin plus 5-FC. That point about doing serial lumbar punctures can't be overstressed. Lumbar punctures typically recommended at day 7 and 14. These people, in my mind, often should be in the hospital. We'll talk about high dose amphotericin in a moment. This is the key point. Successful induction therapy is when you've got some clinical improvement and negative CSF cultures. Reminder, do not check the India ink and the CSF cryptococcal antigen as your marker of success, because those often will be positive at week 2. That doesn't mean that the patient is failing. It's really clinical improvement and negative CSF cultures. In fact, the DHHS goes so far as to advise us not to check cryptococcal antigen titers because they can be quite misleading. That is, not after the initial titer, which is positive, there's not a value of doing serial titers. And then Mike's point about intracranial pressure can't be overemphasized. I'll just mention this briefly. Because of the interest of time, we probably won't have time to explore this in detail, but there is a really important study that I'd suggest taking a look at from a couple of years ago, looking at a single infusion of high-dose liposomal amphotericin, then followed by fluconazole and 5-FC. And when this group compared that to standard therapy, which is a week of amphotericin and flucytosine, followed by fluconazole, you can see comparable outcomes on your right. And then this is the study that Dr. Saag was commenting on, the COAT study, which led to the concerns around early ART. So where the IAS-USA panel ended up is kind of where I think Dr. Armstrong was, which is with monitoring treatment of intracranial pressure, as soon as your patients have improved, have control of intracranial pressure, have negative cultures, and you're getting control, that's when you should start. And that's usually about 2 to 4 weeks after starting antifungal therapy. That's a good time to start. We have a number of cases, but I'm happy to see if there's any comments. Dr. Saag, I think you're monitoring the chat, and so if there's monitoring the questions, but is there anything you want to pause on here, or shall we go on?
No, I think we can move on. Not seeing any questions related to that. I think we've covered it pretty well.
Terrific. These are the guidelines that I alluded to just a moment ago, and take a look. There's a more extensive discussion of this important topic in that particular guideline. All right, now we're going to shift gears completely. So we went to when to start ART in a complicated situation. Now we're going to talk about what to start, and we're going to talk about what to start in the context of pregnancy. So this is a 35-year-old woman with HIV. She's on bictegravir FTC TAF. She's virologically suppressed. Her CD4 count is 500. She's found to be pregnant, and she's at the end of her first trimester. So she asked 2 questions. What regimen is safest for her and her baby? And she also asked, can she switch to the shot? Her partner is on cabotegravir rilpivirine. Can she switch to that instead of the pill that she's taking? So what do you recommend? Dolutegravir plus TAF FTC, because that's the one and only preferred regimen during pregnancy. Do you recommend continuing her on bictegravir FTC TAF? Do you think that it's okay to switch her to cab rilpivirine, the shot? Do you switch her to a boosted protease inhibitor plus TDF FTC? Or do you consider something else? So let's see what you all think. Okay, so most of you are going for continuing the bictegravir FTC TAF, a smaller percentage, but some would like to switch over to dolutegravir TAF FTC. Now, I will say in my own practice has changed in this regard in the last few years. So it used to be one thing and now it's different. So what do people think on the panel? Let's see, who is raising their hands? It looks like Dr. John Brooks is going to jump in and followed by Dr. Chu. They were neck and neck. It's kind of like a Jeopardy thing. They were buzzing in at the same time. So
I know we need the music. Yeah. So yeah, that's a good question. I mean, I will first emphasize that integrase inhibitors are safe in pregnancy, and they're the preferred choice in many circumstances. I'll also note, I think in the cab rilpivirine, I have to check, but I'm pretty sure that it is not approved by FDA in pregnancy. The combination of, sorry, excuse me, I misspoke. It's just not approved in pregnancy.
Got it. And Dr. Chu, did you want to pick up there or either agree or disagree?
Sure, I'm happy to. I mean, I think that overall, this patient seems to be doing very well in their current combination of BIC/FTAF, and certainly it could be continued. It sort of got upgraded a little bit to now it is clearly sort of described as one of the preferred. With that said, I mean, I would sort of just take this moment as a like one of curiosity and kind of explore maybe where is some of this interest in the Cabral coming from, because things might change during this pregnancy or even after, and so I think if I knew that someone was interested in, sort of starting that conversation about long-acting injectable, I think this may be a moment to sort of kind of leverage and sort of take it to the next step because, the eligibility considerations, I think, for Cabril sort of pregnancy aside, will probably require a little bit more work in terms of, gathering additional history and that kind of thing.
Yeah, it's really kind of interesting, and John Brooks may be able to comment, but I think one of the reasons we were able to consolidate the PEP recommendations is the safety of bictegravir FTC-TAF being approved for pregnancy. It was slow to come. The dolutegravir even had a little bit of a bumpy course early on with concern about neural tube deficiencies or at birth, but that was disproven. Then BIC didn't have enough data. Now it does. So either of those AB regimens are very good and have made our life easier.
Can I go out on a little bit of a limb here?
Sure. Yeah. Let's see how far let's see how far out you go, but let's go ahead.
I agree with everything that's been said. If this patient was not controlled and was not, and oral therapy was not working, even though I just don't want to give the sense that cabrolpipirine should never be given in pregnancy, because in the absence of any other option that is going to work, it is something that I have and would pull in if that gave the chance of getting a patient who has struggles with oral adherence to get to undetectable. And so, no, it is not what we should be grabbing in this patient at all. But I wouldn't say that it is never appropriate in certain very specific circumstances.
Yeah, that's an important point. Let's let Dr. Chu get one more comment in, and then we'll share some data.
Yeah, no, I'm really glad that Dr. Armstrong brought that up, because I think that is sort of the or it had been sort of the unspoken question, because I think there have been a number of case reports, case series that are now in the literature sort of describing exactly sort of that scenario of like when you might actually need to consider it in pregnancy. And given that there's a slightly shorter or more compacted timeline that one might need to consider it, it is, I think, it's important to know if there is that interest so that you can sort of move towards that if that, seems to be sort of where the benefit ends up shifting.
Great. There's a little bit of data coming on that point that's not even on a slide, but I'll share because I just saw it yesterday. But let's see how this has evolved. Basically, whoa, that was a jump to the end. Let's see. I will be right back.
Yeah, while you're
yes, yeah, you can.
While you're going there, I'll filibuster for a minute.
Yeah.
But I think the story with dolutegravir was really interesting, because those of us who have been at this a while, the story was almost like copy paste with efavirenz, which early on had some quote neural tube issues, and then with more data was proven to be safe. And the same thing with dolutegravir. And the take home point was that it all seems to be related to folate, and folate is really important for neural tube development and closure. And so as soon as someone is determined to be pregnant, getting folks on folate, it's really important regardless, but especially if somebody's a person with HIV.
That's a really important point. There has been an evolution here, and I hope that this is showing you a sign that says bictegravir. Okay.
Yeah, there you go.
What I don't know is it full screen view, but hopefully it's coming. Dr. Armstrong we were on a green room call, and I was having some slowness on my computer, and it seems to be persisting. What do you see now, Mike?
We're seeing your sort of
so
it jumps right to some. All right, you can go back.
Okay, sorry.
People have to kind of close their eyes.
Yeah, close your eyes, because I don't want to unshare, because that didn't seem to work out too well. But apologize for the
Yeah, keep
with a little
going.
bit of a
Keep going, keep going.
what
Nobody
do you,
pays
what do you,
attention.
what, yeah, that's right. Don't. Okay.
There we are.
There we go. Okay,
Yeah.
so what has happened just in the last few months, June to be specific, is the DHHS updated their guidelines, and as Dr. Chu said, they bumped up bictegravir FTC TAF as now co-equal to dolutegravir plus TAF FTC as your two first choices. Where they put ritonavir boosted darunavir, and here the darunavir and ritonavir have to be given twice a day, is as an alternative. So that's a change from their last iteration. Where they put cabotegravir rilpivirine is on the next slide, but the only time that they like ritonavir boosted darunavir as their top choice, and I would agree with this, is in someone who's recently had cabotegravir for PrEP and then acquired HIV. Not a common scenario, but an important scenario. Here are the safety data that led them to promote bictegravir FTC TAF. One is they use the antiretroviral pregnancy registry. Once you get up to about 400 or so first trimester exposures and there's no signal for harm, then they consider that to be supportive, and that's where they've gotten to recently. And then they have two studies that show that the drug levels of bictegravir during pregnancy are lower than before pregnancy or after pregnancy, but they're still high enough to keep the virus suppressed. So that's really what that was the reassuring data. So 5 years ago, 3 years ago, we were still using dolutegravir TAF FTC. In the last 6 to 12 months, I think we've been moving over to this. Here's what was presented at CROI this year, and this is an important point that was made. There's very limited data on injectable cabotegravir rilpivirine in pregnancy. In fact, these are the data on cabotegravir rilpivirine in pregnancy. 23 pregnancies in the U.S. This was presented by Bill Short at CROI this year. 17 of those pregnancies, the woman was on cab rilpivirine prior to pregnancy. 13 of the pregnancies, they stayed on it, and viral loads were suppressed in 92% of those 13 people. 6 people switched to cab rilpivirine during pregnancy, and at the time of delivery, 5 of those individuals, 83% were suppressed. 21 live births, 1 miscarriage, 1 stillbirth, no infant transmissions. I'll underline again, no infant transmissions. So where we are now is, I think, what was said. We're not ready. It's not ready for prime time. I don't think we would do this routinely. This is very much a case-by-case basis. It's not recommended. There was one interesting study that I came across just last week from the University of Nebraska group. They do a lot of PK work in long-acting injectables. And what they found some evidence for is in a small number of women, like just a few, a handful, that when given monthly, cabotegravir rilpivirine levels seem to be okay. When given every 2 months, that was kind of falling down to a place where they were getting worried. So if I were to do this, and I would do it only, with a lot of shared decision making in the instance that Dr. Armstrong and Dr. Chu said, I would give it monthly if I was going to give it. So, any comments on that front? Okay, I'm going to keep going, and if questions come in, we can always backtrack as needed. So, okay, so we were talking about adherence just a moment ago, so let's probe that a little bit. So,
sorry,
yeah.
Raj, just to interrupt. There was one question from Louise Austin that just came in.
Yeah.
From Ryan Health. Do you consider someone who becomes pregnant on cab rilpivirine, they're already on it? Then I guess it's a shared decision making, as you were just alluding to.
Yeah, what most of the guidelines committees would say is we don't have enough evidence to do it routinely, and so yes, if they're on cab rilpivirine because they prefer to be on it, but can take oral therapy, I think I would advise them to take oral therapy because we just have so much more information. If the only way they're going to stay suppressed, because of a variety of considerations, is to be on injectables, then have that conversation. We just have very limited data, most of which I've shared with you already. So, alrighty. Adherence, though, let's go to that next. 50-year-old man with HIV, diagnosed in the 1990s. He had been on efavirenz FTC TDF. He did have a K103N mutation, the signature mutation for efavirenz, but no other mutations, no other NNRTI mutations. He has not been exposed to hepatitis B. This individual is surface antigen, core antibody, and surface antibody negative. He's having some difficulty remembering to take oral therapy, but his CD4 count is 500 and his viral load is 20,000. And he too asks you about injectable cab rilpivirine. Would you recommend the injection? Yes. Would you recommend against it? No. Or are you unsure, or it depends on the situation? So let's see what this one I'm really interested to see where people are at. Looks like one third, one third, not exactly one third, one third, one third, but about half would recommend it. 14% say no, and then a good proportion want to have a longer conversation. So what does our panel think? Dr. Armstrong, what would you do?
Obviously, a longer conversation or a conversation is always important. I see no reason not to proceed with rilpivirine in this patient. It sounds like you have a good genotype. There are no other mutations in the K103N, should not impact rilpivirine. I worry a lot when I don't have that information and I know that somebody has failed an NNRTI in the past, but here you have it. He is having trouble. And I think this is, and I know that he is viremic, and we have increasing data that I think you're going to talk about, and I'm going to talk about long-acting therapy in viremic patients. And so these are the kind of folks for whom I think this is a game-changing drug.
Terrific.
Now, there is talk about if somebody's CD4 cell count is 500, do we start someone who's viremic? I personally would do it.
Okay. Dr. Chu, it looks like you're going to comment here as well.
Yeah, I mean, and I was just going to add, I think that, I also would want to know a little bit more about the resistance history just to feel, much more confident on whether the K103 is the one and only. And with that said, I think if something emerges that there are more non-nuke mutations, I think, this is maybe where you could consider Len just as part of that sort of larger conversation, given that this person is very interested in, sort of transitioning off of orals. And I guess just to sort of flag, I think if this person was diagnosed in the 90s, I would hope that they were offered vaccinations at some point. So I do find the Hep B antibody being negative a little curious, and I want to know more around that as well.
Yep, terrific. Bookmark that for a moment because we're definitely going to come back to Hep B and Hep B exposure in just a moment. In fact, in that very next case. So, okay. So as people know, I'm sorry, I'm having tech problems here. Can people still hear me?
Yeah, we can still hear you. I think
I lost my Zoom screen.
Yeah, I know. If it's helpful, we might be able to have the IAS-USA team launch your slides for you and just say next slide. That might go.
Okay, yeah, that would be great. Sorry about that.
Fatima, can you help us with that?
Yeah,
Tom?
I lost my Zoom screen when I clicked, so I apologize.
Yeah, so Tom's working on that right now.
Okay, terrific.
So I might add, there's another Dr. Gandhi who started exploring that notion of treating folks with viremia, and the controversy at that moment was that the official package insert says you want to start rilpivirine on people who have suppressed virus. So, that was counter. But as you're about to show us, I think there are pretty good data that it's almost beyond even harm reduction now. Just somebody is having trouble keeping up with their regimen, then this is better than going up and down especially on a integrase inhibitor regimen.
Terrific. I'm seeing the slides, so I think Tom has come to the rescue. Thank you.
Yep.
Appreciate it. So I think all the points really have been made. Let's go to the next slide. If you advance.
Yeah, so Ala from MedStar raises that point. He says, I thought we were supposed to wait and weren't supposed to start when there's detectable virus, so maybe you can address that.
So as Mike was just saying, this is what the FDA package insert still says, which is this is approved for people who've got no history of treatment failure, who are virologically suppressed, and don't have known resistance. It's typically given every 2 months in a clinic setting. Go to the next slide, please. So briefly, but I'll be brief here, some of the main risk factors for virologic failure in people on rilpivirine come from the Atlas 2M, and FLAIR studies. In those studies, about 1.5% of people had virologic failure. That's a number that's pretty much uniform throughout many of the injectable ART studies. If people had rilpivirine resistance, and that was detected on proviral genotyping, a topic we'll come back to, A6, or obesity, body mass index of over 30, if they had 2 or more of those, that's when they had a very high rate of virologic failure. If they had a single one of those, then the rate of virologic failure was about 2% or less. Let's go to the next slide. I think Dr. Armstrong is going to talk about this, so I'll be briefer here. There's a very important study that was presented last year, 2024, and it's going to be published soon, called Latitude, that looked at people who are having adherence difficulties on oral therapy. They got conditional economic incentives, essentially cash, or financial support until they got virologic suppression. Then they got randomized to cabrolpivirine monthly or daily oral therapy. Let's see the results. If you click once or twice, yeah, one more time is fine. Regimen failure, virologic failure, treatment-related failure were all lower in the injectable arm. When you put all those together, the injectable was superior to daily oral ART. Let's go to the next slide, and I'm going to ask you to click a couple of times here, go one more time and one more time. Here are 3 representative studies, one from San Francisco, where 129 people who were viremic, now viremic people with a viral load in the mid-40,000s got cabrolpivirine. Rates of virologic suppression at a year were 98%. 5 of them went back to oral ART. I'm going to be explore less on the OPERA database. These people were just barely viremic. The median viral load was 120, so just above 50. They also had high rates of virologic suppression, but a really important study from Mississippi, viral load of 150,000, viral load suppression rates of 100%. And I'm quite sure Dr. Armstrong is going to show the latest and I think really important data from Emory that really gets to this point. I won't go over that here. So the next slide is my own take. So for someone who's virologically suppressed and don't have known resistance, then clearly this is a good option. Almost everyone will stay suppressed. I do mention that there's a small risk of viral failure, about 1% in resistance. So I do monitor people, of course, but it's a very good option. Next bullet, please. For someone who has NNRTI mutations, the point about K103N is a really important one. In the Atlas and FLAIR studies, you could be in those studies if you had K103N, but there was only about 20 or so people who had it. There's a growing experience with it. This is where it's a case-by-case basis. I often will still try to push forward with oral therapy because I do worry about low-frequency rilpivirine mutations. But if that's not working out, then the next slide. Next bullet, please. Then I think CAB plus lenacapavir studies are being done. 2 studies in the ACG we hope to launch this year will give us some more information. There's case series that have shown good results with that. I have a couple of patients on this and with good results. And then the last bullet is the important one, and I think no one would disagree, that for people who are viremic, have a low CD4 count, not able to take oral ART, not only do you offer this as an option, but conjoin it with addressing the barriers to engagement in care. It's not just the drug, it's the barriers that lead to difficulty adhering that really has to be the focus of our attention. So I'm going to pause. Why don't we go to the next slide and we'll see if our panel have any concluding thoughts before we tackle the fraught question of hepatitis B core. Okay, I'm seeing some smiles, so I'm going to push on. So 50-year-old man with HIV. This time, though, his surface antigen's negative, his surface antibody is negative, but he is core positive. So he has that not uncommon scenario of isolated hepatitis B core. This patient had received the Hep B alum vaccine, the so-called NGRX vaccine, 10 years ago. Didn't, though, achieve a seroprotective response. His surface antibody never went above 10. His CD4 count's good, 500. His viral load is suppressed. He asks about switching to injectable cabrolpivirine. So I'm going to ask you 2 questions that are kind of related. One is, what do you recommend? First, do you recommend switching to cabrolpivirine immediately? Do you recommend retrying the alum vaccine series and then switch to cabrolpivirine? The third option is to give the CpG vaccine. This is the Heplisab vaccine, a newer vaccine, and then switch to the injectable. And the point here is that we're switching off of tenofovir. And I didn't make this point, but I'll make it now. This patient right now is on bictegravir FTC TAF. Sorry about missing that. Fourth option is give him the vaccine series, but only, and give him the CpG vaccine, but only switch him if he gets a seroprotective response. And then the final option is don't switch too high of a risk. So what do you think? Let's see what our audience says, and then I bet our panel is going to have something to say about this. So it looks like the most common answer is give him the CPG vaccine, but wait, and switch him off of the bictegravir FTC TAF only if he achieves a seroprotective response. That's the first choice. The second most common was give him the vaccine series, but then it's okay to switch at that point. What does our panel think? Dr.
Well,
Brooks, would you like to jump in here? I saw you unmute.
Well, yeah, I think the first thing, and thank you for telling us what his regimen was at present,
Yes,
because I think it's
yes,
important.
yes.
He with that regimen, he may be suppressing. This is what I think people are recognizing and are concerned about. He may be suppressing chronic hepatitis B infection. Uh, and possibly, it's pretty rare. And these anti-Hep C B people are always hard to deal with. I mean, I would favor, but I'm really interested to hear what others have to say because I don't deal with this that often. So I'm looking to learn as well. But I would favor answer D, which is try the Hepatitis vaccine. It's been shown in non-responders who have HIV to have a slightly increased capacity to achieve a serologic protective level, a level of serologic protection that prevents uh, hepatitis in case he doesn't have it. And then if he does achieve that, you could feel comfortable switching. You're not going to have to wait all that long. It depends on how quickly he wants to change. You could offer the vaccine, and it's going to be a couple of months until you'd know, presumably, that it had taken.
Good point. We usually check it 1 to 2 months later, so that's true. Other comments? I
yeah,
heard someone else trying to jump in, but go ahead and jump in now.
I think that was me. But so there are data from the VA presented, I think, at ID Week about 3 years ago. It hasn't been put out in press yet, as far as I know, but it showed very nicely that the highest risk of reactivation in this setting is somebody who is surface antibody negative, but antigen positive. So surface antigen positivity is really the biggest risk. I think it's like 10 to 12% of a major flare. In the people that are isolated core, like in this individual, the risk of that type of flare is very, very low. And that's probably the best situation other than having core antibody and surface antibody positive and surface antigen negative. So that's what we're trying to achieve by giving the HB CPG vaccine. I'm comfortable with either C or D here. I think both are good. Just the risk is so low in this setting on its face, even without the vaccine.
Yeah.
I think you're okay to move forward. This is just an opinion, but it's hard to put it all together.
We're going to get Dr. Ghanem's going to be the comment, but Dr. Brooks said, hold that thought.
I will hold it.
Yes.
So it's interesting. What Mike said was exactly what was suggested by one of my Hep B colleagues at Hopkins when we had a similar situation. And given the answer to that, because I said we're going to wait until it's greater than 10, et cetera. And the answer was, it probably doesn't matter. The risk of reactivation is so low that you can just ignore the titer and switch them off. So I have to say that I went with D, but I trust my Hep B colleagues into it.
I think I know who you're talking about. Dr. Brooks, last word.
I do too. And I'm not a gambler, so I'm probably going to go with D as well. But I did want to make one point, which is, Raj, is this person cold negative for surface antibody, 0, or have any detectable level, but it's under 10? Because if he had demonstrated some response with some detectable level, I might be more prone to consider C.
Yeah, that's a really good point, and not one that I explored in this, but that is a very fair point. If there's a difference between being 3 or 4 or 5, where they might have had a positive titer and waned, as opposed to being flat 0.
Right.
So
because we know for occupational settings,
Yes.
people who've had any level measured over 10,
Yep.
even if it wanes, they're considered protected for life.
So hold that thought about titer. Let's go on to the next question. It's related, and it has to do, let's have you advance, Tom. And then what we're going to ask you is same patient, same regimen, next slide. And we're going to ask you how many doses. So you decide to give them the CPG vaccine. We agree. How many doses are you going to give them? Are you going to give them 1 dose, 2 doses, 3 doses? Are you on the side of no vaccination? Let's see what our audience thinks, and then we'll maybe we'll just have one of you comment on this one. So our audience is going to weigh in on 2 doses. Very good. Okay. We're going to get into a nuance in a moment, and then someone went past me a little quickly, but I think some people also would give 3 doses, and there's something to be said there as well. Let's see what our panel thinks, and maybe one or two of you take the reins.
Dose.
Okay.
Is that, Raj, I'm trying to remember in my head that figure from
Yeah.
the paper. And I'm pretty sure you didn't get a lot more with the third, but I might be wrong.
Yep.
That's not what I got to know.
A little, but not a lot.
Yep. Perfect. Let's see what the data show. The survey says. Let's go ahead and see.
How far apart were those lines?
Go ahead. And I apologize for not having control. I'm feeling a loss of control, but go ahead, Tom. You can take us one more slide ahead. So.
And Raj, you can add 10 minutes to your timer because seriously, we're incorporating questions as we go.
Terrific.
So Raj, can I throw out a question? What if you don't have the CPG vaccine?
So let me comment on that, and then we'll go on. I would say if I did not have the CPG vaccine, I only had the alum vaccine, or the there's Recomvax, there's Endurex. Who knows what's going on at the CDC today with alum, but leaving that aside for the moment, I would reimmunize him with the alum vaccine, with Endurex. Yeah. And I might be able to show you some data on that in just a moment. So this is Dr. Saag's point. Hep B reactivation really is uncommon after stopping tenofovir. It's a really important point to attend to. That's why I brought this case, is because I want people to think about the possibility, but it's not common. So 2 bits of data that came out this fall, one from the European meeting from the Swiss HIV cohort, a big cohort. These people were all surface antigen negative. That's the key point. Surface antigen negative, core antibody positive. They did switch off of tenofovir. About 1.4% of them, before they stopped tenofovir, had a detectable Hep B DNA, and that went up slightly to 3.9%, but it was barely detectable. All of the people who went up were below the quantification limit, and the really important point is that liver enzymes did not go up. There was no real statistically significant flare after stopping. Another study, the Barcelona study, 741 people, this time they all switched to cabrylpivirine, and there were no Hep B reactivations among those people who were surface antigen negative. And I'll again emphasize surface antigen negative, including those with isolated core. So next slide. One of the people I work with made this really cool animation. I'm going to ask you to click once. So if you're switching to tenofovir sparing regimens, here are your 3 scenarios. You've got someone like my patient who's non-immune, not infected, his surface antigen's negative. I would vaccinate with a CPG adjuvanted vaccine, and if I didn't have it, I would give the alum vaccine. And then if they seroconvert, I would annually test them if they have ongoing exposures. If they don't have ongoing exposures, then I think if they're positive, then it's less important to keep testing them. The next scenario, go ahead and click, is the scenario that Dr. Saag mentioned. If their surface antigen is positive, that's not someone you're going to want to you're going to want to keep that person on some Hep B treatment, either tenofovir or entecavir. So if they're Hep B surface antigen positive, keep them on a Hep B drug. And then the last scenario is the scenario in someone who's had prior exposure. Here, I think even if they're not able to achieve a surface antibody response, their risk of reactivation is low enough that it's okay to switch to tenofovir sparing regimen. But what the DHHS guidelines, and it's actually Dr. Ghanem's colleague who writes this guideline at Hopkins and others, they recommend that we monitor ALT regularly, and some experts will even monitor Hep B DNA occasionally if their patient is not surface antibody positive. So bottom line is I would give the CPG vaccine. The last nuance I can put in there, if you go to the next slide, is the data that people were talking about. This is people getting the CPG vaccine if they've never been vaccinated before. I'm not going to go through all the bullets, but I just want to emphasize that you get up to 99% rates, 98.5% rates of seroprotection after 2 doses, and then you inch up to 100% after 3 doses. That's if you've never been vaccinated before. The next slide is in people who were prior non-responders. And in this scenario, the important point I want to make here, this is a recent data, is 2 and 3 doses of the CpG vaccine gets you up above 90% seroconversion. It's better than the alum vaccine. The alum vaccine is 80%. It's not 0. That's why I would use the alum vaccine if I didn't have the CpG, but it's better to get the CpG. But new data came out recently is the next slide, which is you get a bit better durability if you get the 3 doses than if you get the 2 doses. So these are 3 curves. These are surface antibody over time. The lowest curve is if you get the alum vaccine. This is going out to 72 weeks. The middle one is if you get 2 doses of the CpG, and the highest one, highest durability, is if you get 3 doses. So my take is on the last 2 slides. For someone who's surface antigen negative, core antibody negative, surface antibody negative, give the CpG vaccine if you've got it, 0 and 1 month. I sometimes will do the 3 doses personally if a patient has a low CD4 count, prior vaccine non-responder, or if they've got ongoing exposures, just to get that extra durability. As Dr. Brooks said, check that surface antibody 1 to 2 months later, and then we would reimmunize if they don't get up above 10. Mm-hmm. One interesting thing that the DHHS is advising, it's a really fine point, is on the next slide. If you've got someone with isolated core, one other strategy that is reasonable is give them a dose, check their surface antibody 2 months later. If you get that titer above 100, these experts think that you can probably, then you don't need to give additional doses. So that's something you can consider as well. If you don't get above 100, you have to have a lab that will quantitate it for you. If you don't get above 100, then go on and do the rest of your vaccine series.
So there are 4 questions or so. But I think we've addressed them. Becky Johnson was asking about if it goes above 100. You literally just answered that.
Good.
We also have a question of somebody with acute HBV with a surface antigen positive 2 or 3 years ago and then converted. Is that a time to start cabotegravir rilpivirine if the LFTs are normal? And then also alluding to the fact, does the HBV DNA play a role? And that's a couple of the other questions here.
I can briefly, and then I'm happy to have the panel weigh in as well. For someone who has acute Hep B and resolves it, that is their core antibody turns positive, their surface antibody turns positive, and their surface antigen is negative, I think cabotegravir is a fine choice. If they get in the future, if they have another immunosuppressive illness, it is possible to reactivate, but that would be something. For example, if they needed cancer chemotherapy, that's contingency. As far as the DNA, the DNA. A long time ago, I did a study where we took about 100 people who had isolated core, and we did DNAs in all 100 of them, and only 2 people, 2% had DNA. It's called occult Hep B, and so sometimes I will do a DNA just to be sure in someone who's isolated core positive, but most guidelines are on the end of that most of these people either have prior infection and they lost their surface antibody, or they have a false positive. That's kind of the current thinking on the isolated core. So, yeah.
Sorry, 2 other quick questions. Is there a threshold for CD4 where you might give the vaccine?
The 3 doses?
Yeah.
I always give the vaccine, but if the CD4 count's less than 200, I'll often go for 3 doses because I feel like there's a lot of data that they have a tougher time, getting a good response.
Okay.
In that very important Beehive study, the data that we were talking about, the median CD4 count was very, very high. It was probably over 500 or thereabouts. And so, I worry more about people with CD4 counts less than 200.
And Joe Yao was asking about the data for greater than 100 rather than the standard greater than 10. I think you were saying that just in terms of giving the next
and that's the anamnestic response. Essentially, that's kind of a signal that your patient probably had a infection before and lost their surface antibody. So you give them a single shot, you reintroduce the antigen, and their memory kind of kicks right back in, and they get a rapid increase. So that's why they chose that as that's kind of circumstantial evidence that you've got someone who's got some memory there, immunologic memory.
Yeah.
Happy to have others jump in, but I'm
Yeah.
kind of rapid firing these. So yeah.
Yep, that's good.
Terrific. All righty. Let's go on to another scenario. So this is a woman who's in her 50s with a CD4 count of 500, a viral load of 500,000, no resistance mutations. She's got hypertension and GERD. She started on bictegravir FTC-TAF. Her viral load goes down nicely to 100, but just over the next year, it never goes down below 50. It gets stuck between 50 to 100. Next bullet or advance. How would you manage this patient? So here are your choices. Would you add doravirine? Would you intensify therapy? Would you change your regimen to a boosted PI because you're worried about resistance? Would you evaluate her for drug-drug interactions, or would you send a proviral resistance genotype? Let's see what our audience thinks, and then we'll turn to our panel. Okay. Our audience is most worried about drug interactions, and also a few would like to also think about a proviral resistance genotype. What does our panel think? You unmuted, Dr. Armstrong.
Sure. I can tell you that I agree with our audience that you want to evaluate for drug-drug interactions. This is an incredibly distressing problem for patients. They have these low-level viremia. Let's say there's no drug-drug interactions, and there's anxiety about how to get that down. Obviously, there's a drug-drug interaction. You re-query them about adherence, all those issues. But not infrequently in this scenario, none of those circumstances are at play. And the inclination, I think, is to think about resistance. I will say that in somebody who truly has resistance, their RNA is almost never going to be only 100 copies. And I find no value in this scenario to a proviral resistance genotype. And we've done 100 studies looking to see if we add on extra drugs, if that makes a difference, starting in the old days with abacavir and so on, and it doesn't. And so while this patient may be at slightly increased risk of developing resistance with low-level viremia, I find these tough, but there's often not a lot you can do about it.
Yeah, the drug-drug interactions could be very real with the history of gastroesophageal reflux if they're taking divalent cations as an acid, and that can interfere with the absorption and the use, the activity of bictegravir. However, this is biology. People that have high baseline HIV RNAs have a larger reservoir of latent virus, and it spills off just spontaneously into the circulation where you can detect it, but there is no evidence that that means there's ongoing replication, as Dr. Armstrong said. So I think we just reassure the patient once we've ruled out the drug-drug interactions, keep them on the regimen and move on.
And how would you counsel them about U equals U?
Because U equals U, it's not just truly undetectable, it's low, but I'll turn it to Dr. Brooks, who was our
Below 200.
Yes, below
Below
200.
200.
I wanted someone to say that really loudly because that's the number. Is below
200.
Yeah. And this is a very important question. Dr. Chu is going to expand on this. Patients do worry, providers worry, I understand, and that's a very good message to be able to tell your patients is that all the studies, the Partners 1, the Partners 2, all the studies use the threshold of 200 or less. So this patient, U equals U, she's untransmissible. Dr. Chu.
Can I add one thing?
Yes, please go ahead.
That also intercurrent STIs didn't seem to change your risk for U equals U either. That's important.
Oh, that's important. I did not know that. Okay, good to know.
Maybe clearly you can confirm that. That's what my last reading was.
Very good. Okay, and you're getting a thumbs up from Dr. Ghanem. So.
That's important because people worry about that.
Mr. STI gives you a thumbs up. So.
Yeah, I mean, the only point I wanted to make here was actually, though, I mean, I agree with everything. And for people who are pregnant, though, I do think the sort of conversation feels different. The HHS guidelines still, sort of anchor around 50, but, obviously we're seeing low-level viremia in pregnancy as well. Not that you would do anything different necessarily, but the conversations do feel different again, because, then we're going to be more worried about transmission to baby.
Yeah.
Good point. Let's go ahead and make it. I think all the points have been made, but I might just sum up if you go to the next slide. This person indeed was taking multivalent cations. That was, as the audience and the panelists supposed, was the concern. A couple of reminders: there's calcium, of course, there's magnesium, there's iron, but zinc is one that I've seen a couple of times recently because it's in some of the bodybuilding supplements. This particular patient wasn't bodybuilding, but another one of my patients was, and it was the zinc that was the problem. So yeah, do query not only about things you might be prescribing, but things that people might be taking. The other points about the proviral genotype, there's a slide that I wanted to show in a moment that I'll talk through now. Proviral genotyping is, just as a reminder, you're looking at the DNA, and it turns out that 95% of the DNA is defective. So these are the steps that I think our panel already walked us through, so I won't belabor this. The last couple of points I do want to emphasize, though. Dr. Armstrong mentioned one of the first studies I did in the ACTG was one of those intensification studies where we added an integrase inhibitor to 3-drug therapy, try to get that low-level viremia to go away, and there was no effect on low-level viremia. And there's half a dozen other intensification studies. So adding drugs, I think, is really not the answer. And then similarly, changing drugs doesn't really help. So I agree with the audience, 90% of you, as well as the panel. Let's go on to the next slide. This is a slide that I'd like to show on the proviral genotyping because I think it brings a lot, brings it all together. So the next slide. So what this is doing is it's looking at the DNA, not the RNA. We do it in people whose viral load is typically below 200 copies, typically below 50 copies. Here's the important point, though. Most of that, probably 95%, is defective. It's not replication competent. So your specificity in terms of what you're measuring is not very good because a lot of what you're measuring is not replication competent. Sensitivity is also a big problem with proviral genotyping. There was one study where they had 100 people who had an M184V historically. They had an electronic document that said, I have an M184V, and they did a proviral genotype. They were all suppressed at that point. Only half of them could they find it. So it's got low sensitivity, and that was published. And then more recently, a CROI presentation, they did serial proviral genotyping in people on therapy. And half of the time there was variable detection. You found a mutation one time, the next time it was gone, or vice versa. It's not really validated. And so next slide, next bullet. I really don't send it, as Dr. Armstrong said. If it's been sent and you have a mutation, it's somewhat hard to ignore, but I don't send it routinely because I find it gets me into more trouble than helps. Especially if you have a patient who's been suppressed. Sometimes we're asked, should we do a proviral genotype before switching to cabrilpivirine? I don't do that in people who have been suppressed because I think it'll end up being misleading.
Yeah.
Yeah.
And that wincing article that you have listed
Yes.
is fabulous for
Yes.
describing the rationale of why it's not that helpful.
Yeah, good point. That's one to go to. Let's go to the next case, and I think we're going to be right on time, if I'm not mistaken. So this is a very common clinical scenario, not an ART issue, but a common scenario. 50-year-old woman, viral load of 500,000, CD4 of 500, hypertension, started on bictegravir FTC-TAF. Her viral load goes down below 20. But over the next months, year or so, her weight goes from 60 kilograms to 75 kilograms, and now her body mass index is 29. Her ASCVD, her cardiovascular risk score, is 6%. What do you do? What do you recommend? Do you change your regimen to doravirine plus TAF FTC? Get her off the integrase inhibitor? Do you change your regimen to boosted darunavir cobicistat FTC TAF? Again, stop the integrase inhibitor. Do you start a statin or do you start semaglutide? Let's see what our audience says, and then I see some smiles. I actually see Dr. Chu smiling, so I might call on her first.
Sure. Should I go ahead? I'm looking at the audience.
Yeah, looks like statins lead the list, but a third of people would like to start a GLP-1, and then a few would like to change your regimen. So what do you think?
Yeah, I mean, I was just going to applaud the audience. Just, I think, there's plenty of evidence to say, this might really A and B is sort of not where we're going to see the sort of change that we might have hoped in terms of sort of weight loss. And so, to me, I think, right now you could certainly offer semaglutide, and I think with the 6%, I take it that you've sort of put it there on purpose. I think I would sort of start that conversation. I mean, 6% isn't super high. It's obviously not super low. And I think if pill burden, for example, was a concern, I would want to just sort of talk to this patient about sort of what the studies show us, i.e. reprieve, and then sort of where the recommendations are, and let her know, the cardiovascular risk is likely only going to increase as she ages. And so it's something that needs to be brought into that primary care conversation.
Totally agree with that. Any other comments? I think you've convinced everyone. Okay. So I agree. I would, in this case, I would start by starting a statin because her ASCVD is over 5%. And as you said, it just goes up from here. Go ahead and advance the slide, please. I started clicking on my computer. So the reprieve study that people are well aware of looked at people who had an average ASCVD of about 5%. And this is where they saw the 35% lower rate of major cardiovascular events, and importantly, a 25% lower rate of death from CVD. Let's go to the next slide. This is where the guidelines have ended up. People over the age of 40 who have a ASCVD of over 5% should start a statin. Any of these 3 statins are considered okay, a strong recommendation. For people with a lower ASCVD, we do just what Dr. Chu said. We kind of start the conversation. If they've had prolonged untreated viremia, low CD4 cell count, we're taking older drugs that had a lot of metabolic complications that might sway you and them to starting. Reminder, this is really important. People with diabetes, all people with diabetes should be on a statin. And this is something I've been doing a little bit more of, is trying to remember the dosing of the statin. The moderate dosing of the statin is listed here. Pitavastatin 4, Atorva 20, Rezuva 10. But as our patients age and their ASCVD continues to go up, don't forget to tweak them up to a high-intensity statin if their ASCVD is above 20%. I had a patient yesterday whose ASCVD was 23%. I increased the statin dose if their LDL is over 190, or if they've got diabetes with other risk factors. That's where you're going to go up to those other doses. I have to refer to these doses. I don't remember them in terms of Atorva 40 to 80, Rezuva 20 to 40. This is if they're on an integrase inhibitor and not on a protease inhibitor that raises levels, or cobicistats. Let's go to the next slide. And I want to round this out, and then we're going to, Dr. Saag, do I have time for one more case?
Yeah, I think so. And then we'll
Okay.
we'll quickly, some of the questions were addressed.
Okay. This I'm going to simplify and say weight gain is an important problem, but changing ART is not the solution. A number of studies, the DEFINE study, and more recently the ACTG doravirine switch study, the DO-IT study, neither of them found a benefit. Let's go to the next slide. And these are the freshest data that we've got, which is a 3-arm study. People like our patient who switched to doravirine or switched their TAF to TDF. 145 people in this ACTG study, and the results are on the next slide. And what was interesting is all 3 of the groups lost weight, but there was no difference between the 3 groups. So I guess going into a clinical trial is good for your weight, but it doesn't matter if you switch to doravirine or not. And so that really is probably the definitive evidence that switching to doravirine, which we had some hope might help, really isn't going to be the solution. And then they sliced and diced it in all different ways, and they couldn't find any group that it really helped. So, all right. Happy to take a question or two, and then we'll do the last case, which I call my very special bonus mystery case. Let's go to the next slide.
Okay.
While we're, this is just to say that semaglutide is something to consider. Right now, I reserve it for people who have obesity or diabetes, but there's an accumulating bit of data around semaglutide. Here are two studies that I'll refer you to read at your leisure. Both of these were in people where they gave lower doses of semaglutide. One was for metabolic liver disease, and one was for lipohypertrophy, and important results. So yeah, you want to do the question?
Yeah, so we'll go a couple real quick. So Louise Austin asks from Ryan Health about a low level of viremia and cabrylpivirine, which is complicated, right? But I guess the answer is
probably the same principles. If it's below 200, and look for you don't have the oral therapy, you don't have the oral issues, and people are seeing more and more of this kind of low level viremia. But I don't think I would use.
It's a little bit different for PrEP when you have potentially the Levi syndrome, but this is for treatment. It's a different story.
Oh, sorry, I misunderstood.
No. This was about treatment. This was cabrylpivirine, not just cab alone. Okay, so Dr. Zahid in Evansville, Indiana, may be unrelated, but what's your thought about a patient who has undetectable viral load but compliant, but CD4 continues to decline? A little bit different story, but basically
CD4 decline. Yeah, really, it's not one of our cases today, but it is important. I would say what I tick through is making sure there's not some other reason that the CD4 count's going down: alcohol use, vitamin deficiencies. Sometimes they're on a drug like trimethoprim sulfa or it's hypersplenism. That's been the most common, is they've got hep C or they've got alcohol use disorder, and they have a big spleen, and then their CD4 count goes down. One time I had a patient who had radiation therapy for cancer. That was the cause. And then the last time, rarest thing is I had a person with sarcoid and his CD4 count. So I look for other things, but I don't change ART. So.
Right. And the thing to remember is that the CD4% is often good to look at because it's often a total white count that's dropping, not the CD4 specifically.
And hypersplenism, exactly right. Yeah, that's the clue, is you get leukopenia and then you get so.
The ASCVD does not include HIV serostatus. How much does that affect risk for cardiovascular?
It's a good point. We have people here. There's a woman named Virginia Triant, Steve Grinspoon. They're working on new equations that put in HIV, but you're absolutely right. The ASCVD does not. So right now it's more ticking off if they've got low CD4 count nadir. That's a consideration. It's not in the equation. If they have use of D4T in the past, if they have, a lot of years of uncontrolled HIV. There's not a number you can put on it, but those are the factors.
Yeah. Another question from Peter Solberg about despite some lack of data, somebody's gaining weight on a TAF-based regimen, taking them off the TAF and say just going with dolutegravir 3-TC, not a huge effect.
Not a huge effect. People have done some of those switch studies. If you remember back to the studies where they the tango and the salsa, those kind of very this greatly named studies, which made you smile when you heard of tango and salsa. There was not a big a weight benefit, but there may be other reasons. They're probably going to do fine virologically on dolutegravir 3-TC, but I don't think there's a big weight benefit. So.
Okay, Dr. Africano asks about somebody who's intolerant to statins. I usually refer to cardiologist at that point, but it depends on how high their LDL-C is and that type of thing.
Yeah, I mean, I think these PCSK9 inhibitors are really kind of coming to the fore.
Yeah. And then finally to Dr. Brooks, this is from Lynn, asking about, you indicated with injectable PrEP, after 7 days, there's protection. Does this apply to lenacapavir as prophylaxis as well?
Yeah, excuse me. It's a great question. I saw that also. And it's true that sorry, I've got a bit of a cold today, so I'm channeling Lauren Bacall sometimes. You achieve plasma levels that would provide protection within 1 to 3 days, but how that translates to what's at the tissue level, I haven't seen any data looking at anal or cervical vaginal tissue levels, which would be the sort of what I'd want to look at to be absolutely certain before I made a recommendation like that. The data may be there, I just haven't come across them yet. And I was quick when I saw the question that Lynn put up, which was excellent. I scanned real quickly the lenacapavir guidelines from CDC, and I haven't seen anything in it where they described how long it takes until you're protected. But I'm gonna have to I can get back with you on that detail. I think
Raja,
nonetheless, people want it sometimes in their minds, having one number is helpful. And so, if it's 7 days is not bad.
we,
But if,
we've got about 40 seconds. Raj, I know the case, so maybe
Yeah,
you can just flash it up real quick. And
okay.
uh,
I was going to say if this could also be a reason to have us all back next year if we could.
yeah,
okay, fair enough. But
You
I
have to get all of us back there. So
think it's quick enough, and we can go a
okay.
little bit long. Yeah.
Okay, this will let's do this briefly. I like to go off with this case because I think it makes a really important point. So, a middle-aged man with HIV, virologically suppressed on therapy, has 3 to 4 weeks of abdominal pain and chest wall discomfort. He's seen, has imaging at another hospital, and is found to have a pulmonary nodule and rib-enhancing lesions. Let's go to the next slide. And good transition. Secondary syphilis a few years ago, got treated and had a non-reactive RPR a few months prior to the presentation. He has several sexual partners, doesn't always use condoms, no known TB exposures. He lives in the South, not far from Dr. Saag. His leisure travel is throughout the Central and South America, also Asia, smokes. And when you see him, he's afebrile, no rash, no abdominal findings. His liver enzymes, though, his alk phos is 695, his ALT is 119, his AST 70. The bilirubin is 2.5, and his liver enzymes had been normal at his last visit a few months ago. So I can't show you a pointer, but if you look at that chest CT and in that bottom, it's his left lung. So the right-hand side of the CT, but his left lung, you'll see a nodule kind of sitting right there, right next to the chest wall. And then if you turn out all your lights, you're going to see some nodules in his liver. It turns out in the dark, there's about 7 or 8 or 9 of these nodules. Some of them are poking up near the kind of the edge of the liver. So we're going to ask the question, Mike Milligan. Do we ask the audience to vote? Okay. Do you think it's cancer? Do you think he's got syphilis? Is this pileosis hepatis, which is a Bartonella infection of the liver? Is it fungal or is it mycobacterial? And when I presented this recently, obviously it could be any of them. So that's what that's what our audience said. But it is only one of them. So yes, let's see what our panel thinks, and then we'll go from there.
The last 3 are unlikely with no fever or skin rash. So
yeah.
Alkaline phosphatase. Look at that alkaline phosphatase.
So go, Khalil.
Yeah, what is it?
Okay, Dr. Ghanem.
I mean, that's the only thing. That's the only thing that gives you a little bit of a clue with an elevated alkaline phosphatase, ALT, AST that are less elevated, but elevated. Known normal liver functions not too long ago. Known history of secondary syphilis, which means that he's less likely to have syphilis manifestations again if he were reinfected. So, I mean, you're tempting me, the syphilologist on the panel, to say, reinfection with syphilis and the lesions in the liver. Lung lesions are very, very uncommon in syphilis, which is kind of mind-blowing. But I would certainly treat him for syphilis and see what happens to his lesions 2 weeks later.
Okay, terrific. I wish I had Dr. Ghanem on my side. So let's go ahead and go to the next slide. So what happened here is I sent a bunch of tests, blood cultures, cryptococcal antigen, fungal testing, all was negative. Some serologic testing, repeated his viral load, all was okay. Interferon gamma release assay was negative. I then actually sent him for a liver biopsy, and there was one more test pending. Go ahead to the next slide. And so as he was getting his liver biopsy, I get a phone call with this other test, which I'm going to tell you in a minute, but he gets the liver biopsy, and the liver biopsy shows periportal inflammation and edema, granulomas, and his microstains are negative. So what's the test result that I get while he's having the liver biopsy? Next slide. His RPR is 1 to 64, and it had been non-reactive 4 months earlier. So I did what Dr. Ghanem said, but I gave him 3 weekly shots of IM penicillin because I wasn't brave enough to give him a single shot because this is unusual. This is not common, especially the pulmonary nodule, as you heard. And his alk phos got to normal, his ALT got to normal, and his pulmonary nodule went away, as did his liver lesions. So next slide is the last slide. Syphilitic hepatitis is not that uncommon, but it's important to think of it. The alk phos may be disproportionately elevated, not always. The pathology is what I showed you, the pericholangial inflammation. This patient, we couldn't see the spirochetes on the liver biopsy. Sometimes you can, sometimes you can't. And there are rare cases of gamma, including in the lung, very rare, mimicking cancer, and this is one of them. So that's it for today.
Raj, I wish all of us lived in a place where we could get a liver biopsy faster than the RPR came back.
Yeah. Well, my only comment.
No, it could be translated into it takes a while for my RPR to come back. So it depends. That cuts both ways.
My only comment for Khalil is that a syphilologist sees syphilis everywhere, and once in a while they're right.
Okay. A great masquerader. All right. Thank you, everybody, Dr. Gandhi, the panel, and turn it back over to Dr. Masur to reintroduce Dr. Armstrong, and we'll be wrapping up.